Hi, this is Terri Conneran with KRAS Kickers. Welcome to KRAS Kickers. And today we're going to be discussing the highlights from AACR 2023 with Dr. Ferdinandos Skoulidis from MD Anderson. And this is a session called KRAS Knowledge because it's knowledge plus research plus advocacy equals survivorship. Hey everybody, this is Terri Conneran with KRAS Kickers. Welcome today to our event and talking about AACR 2023 and the highlights in KRAS cancers. And there was a lot of highlights. So I'm really excited to have one of the presenters that did present an abstract at AACR, Dr. Ferdinandos Skoulidis, and I'm getting better about saying your name. Okay, and I'm not going to go through all of his long list of accomplishments. I am going to tell you, he's at the Department of Thoracic, Head, Neck, and Medical Oncology Division, Center of Cancer Medicine at MD Anderson in Houston, Texas. And he has a whole lot of other stuff that he's done and he's continuing to do. But I'm going to have to just jump right at it. So before I say anything else, if you are part of the witness protection program, if for whatever reason you just choose not to have your screen on, we don't want to see your picture, please shut off your screen. Please make sure you stay muted. We've got 90 minutes and let me tell you what, there was so much stuff that was going on around RAS, and this is not going to be focused on just lung. We're going to hit all the highlights as best we possibly can in the period of time that we've got. So thank you so much for joining me today, Dr. Skoulidis.
Absolutely. Thanks, Terri. Thanks for the very kind invitation, and hello to all the KRAS Kickers. It's an absolute pleasure to be joining you from Houston. I just returned from AACR. It was a very busy AACR, and there was a lot that was presented regarding KRAS. So let me share my screen with you, and we will get started. All right. So let's see from the beginning. All right. Can you see it okay? Wonderful. All right. Okay, so these are my disclosures, and I'm going to move straight to the presentation. So some of the stuff you will have seen before, and I'm going to intersperse this with the new data that was presented at AACR so that we can put the new data into context. So obviously, you know that the development of covalent inhibitors of KRAS G12C represents a major breakthrough in the field of targeted cancer therapy. I would argue one of the most significant advances in targeted cancer therapy over the past couple of years. And this, of course, culminated in the regulatory approval of two drugs that are currently available and we can prescribe to patients. The first one is sotorasib, based on the results of CodeBreak 100, a clinical trial that I had the privilege to participate in. But also more recently, last December 2022, we had the second direct KRAS inhibitor approved by the FDA, adagrasib, based on the results of the Crystal-1 clinical trial. More recently, in September of last year, and it's now published, we saw the first head-to-head comparison in the context of a randomized phase 3 clinical trial of a KRAS G12C inhibitor, sotorasib, in this case against the standard of care for patients with following failure of first-line chemoimmunotherapy in lung cancer, which is docetaxel. So this was the CodeBreak 200 clinical trial. Patients were randomized to either sotorasib or docetaxel. And this was a positive study, reaffirming the efficacy of sotorasib that we saw in the earlier phase 2 CodeBreak 100 registrational study. So in this study, sotorasib resulted in a 34% reduction in the risk of progression or death compared with docetaxel and resulted in improved quality of life. It more than doubled the objective response rate. You can see there that it went from 13% with docetaxel to 28.1% with sotorasib. In this study, we did not see a difference in overall survival when we compared sotorasib with docetaxel, but the trial was not powered to detect the difference in overall survival, and following progression, patients were allowed to cross over. Approximately one in three patients crossed over from one to the other arms, therefore confounding the analysis of overall survival.
Let me point out something real quick that you mentioned that I would like to highlight, that you mentioned the purpose of the clinical trial. Okay, what was the purpose of this one? Because a lot of times it's not necessarily looking for one thing or another.
Yeah, the primary endpoint of the study was to look at differences in progression-free survival. So it asked the question whether sotorasib improved progression-free survival compared with docetaxel. So progression-free survival is the time from the onset of therapy until the patient's disease progresses objectively, or so either progression or death. So that was the primary endpoint. And that's how this this trial was designed, and that's the metric based on which it is judged as positive or negative. So this was undoubtedly a positive study and resulted in a 34% reduction in the risk of progression or death with sotorasib. Okay, so what about the activity, recent data regarding the activity of KRAS G12C inhibitors in other tumor types, not necessarily only non-small cell lung cancer? So this was a paper that was published in the New England Journal of Medicine by David Hong and colleagues. It was in early this year. So in this study, in patients with pancreatic cancer, sotorasib resulted in an objective response rate of 21%, a disease control rate of 84%, and a median duration of response of 5.7 months. The median progression-free survival with sotorasib was 4 months, and the median overall survival was 6.9 months. So definitely pancreatic cancer is tougher to crack than non-small cell lung cancer. However, there is hope and there is promise that these mutant selective inhibitors will demonstrate meaningful activity, even in the context of tough to treat metastatic pancreatic cancer. And we know that other drugs in this context, such as adagrasib, have also demonstrated efficacy. We have not yet seen updated results for adagrasib, but the data that was presented last year was particularly encouraging. In that study, the objective response rate in patients with pancreatic cancer was as high as 50%. So we will have to wait and see what's the most accurate estimate of the efficacy. But I think from the data that we have already, there is considerable promise that mutant selective inhibitors of KRAS G12C are going to be active also in the subgroup of patients with metastatic pancreatic cancer that have got KRAS G12C mutations.
How common is G12C in pancreatic cancer? I'm sorry, I'm just going to jump in and interrupt you. I'm sorry.
Yes, pancreatic cancer is typically dominated by G12D or G12V. I think, if I remember correctly, the number is around 4 or 5%. It's kind of the same as what we see in colorectal cancer. So not the majority, but a meaningful subgroup of patients. Okay, what about moving beyond sotorasib and adagrasib? What do we know about other mutant selective KRAS G12C inhibitors that are entering or are advancing through different stages of clinical development? And here we're also going to talk about some of the latest data at AACR, because we saw updated data on new inhibitors. So what other inhibitors are out there? We've got the JDQ443. This is from Novartis. So this is in the CONTRAST-01 clinical trial. So we saw results from this presented last year. The objective response rate, confirmed and unconfirmed, is 45%, and promising efficacy data, 57%. In non-small cell lung cancer at the recommended phase 2 dose. I expect that we will see updated data regarding the efficacy of JDQ443 at the recommended phase 2 dose in non-small cell lung cancer in the very near future. Very exciting data. I'm particularly excited about GDC6036. This is the compound from Genentech Roche. So in this earlier report at ESMO 2022, you can see there that the confirmed objective response rate in non-small cell lung cancer, KRAS G12C mutated non-small cell lung cancer, is as high as 46%. So this is very meaningful efficacy. More recently, we also saw data from D1553, objective response rate 37.1%, and glesirasib, where the objective response rate was reported to be 56.3%. This is data presented at last year's ASCO. Now, in this AACR, so this is fresh data that was presented at the AACR annual meeting. What about the efficacy of GDC6036? This is the compound from Genentech Roche in colorectal cancer. So here, the confirmed objective response rate was 24%. But interestingly, and this was clearly expressed by the author, when we looked at 400 milligrams once a day, which looks to be the recommended phase 2 dose, the objective response rate increased to 31%. And actually, the most updated data, not included here, but the author did speak, Dr. Desai did speak about this, was that the objective response rate went up to 36%. So this is an important improvement compared to data that exists about other KRAS G12C inhibitors in colorectal cancer. If you remember, the objective response rate with adagrasib monotherapy is 19%. It is lower for sotorasib. And here, the objective response rate that was reported by Dr. Desai can be as high as 36%. And as you can see in B, this drug is fairly well tolerated. So the rate of grade 3 and 4 treatment-related adverse events is pretty low. I mean, there is a low rate of grade 3 diarrhea, about 6%. But overall, this drug appears to be safe and effective. And I would be very excited to see to see updated data in the near future regarding progression-free survival and overall survival with this compound. But this was one of the pieces of data that I found particularly interesting and promising in the colorectal cancer field. And in the second part of my talk, we're going to talk about the combinations of these agents with cetuximab, where you will see even more impressive efficacy. Here in the first part of the talk, I'm just talking about the activity of monotherapy, which seems to be kind of impressive. Okay, we also saw first results and about another KRAS G12C inhibitor. This is the compound from Lilly. It's LY3537982. I'm going to refer to it as the LY compound for simplicity. And you can see here results. These are the first time that these results were presented from the LOXO-RAS 20001 clinical trial. So you can appreciate that although the treated population involved patients with multiple disease types, as well as patients that were previously treated with a KRAS G12C inhibitor, the activity of this drug in patients that were KRAS G12C inhibitor naive and had metastatic non-small cell lung cancer was 38%. So the objective response rate was 38%. The disease control rate was 88%.
Okay, hang on 1 second. So, because we're not, you talk real fast. I can follow because I've gotten used to listen to y'all. Okay, but a lot of what you're saying when you say treatment naive, what you mean is it's the first time a patient had a treatment, right?
Yes, G12C inhibitor naive. So patients that had not previously been exposed to sotorasib, adagrasib, or other KRAS G12C inhibitors. So this population of patients that had not previously seen a KRAS G12C inhibitor, the objective response rate with this drug was 38%, which is certainly on par with the activity that we have seen for sotorasib, adagrasib, and the other KRAS G12C inhibitors. So this is definitely a very active drug in this space, and this is the first time that data was presented regarding the activity of this agent. So this would be an additional option for patients as it moves through different stages of clinical development. Importantly, also, this drug appeared to be, the safety profile of the drug also appeared favorable. So no dose-limiting toxicities were observed, and the maximum tolerated dose for this drug was not reached. So this is another promising drug in this field. Okay, I'm gonna now switch gear and go back a little bit to established drugs. Okay, sotorasib and adagrasib, approved drugs, and try to address the question, how, as physicians, how do we go on choosing between sotorasib and adagrasib in the different clinical scenarios? I think this is a question that both patients, but also their physicians, ask me most frequently. We've got two approved drugs. They both appear to be roughly equally effective in metastatic non-small cell lung cancer, with objective response rates from 37 to 43%. and progression-free survival between 6 and 7 months. How do we choose between them? So there are a couple of scenarios where on an individualized patient basis, I as a physician, and this is my personal opinion, might favor one versus the other. When we compare sotorasib and adagrasib, in general, I think the side effect profile for adagrasib, adagrasib appears to have overall slightly more treatment-related adverse events. So you can see that dose reduction due to treatment-related adverse events happened in 52% of patients treated with adagrasib, dose modification only in 22% of patients with sotorasib. It has to be said that most of these adverse events are mild adverse events and can be easily managed. That's true for both sotorasib and adagrasib. But I think overall adagrasib, at least in my experience, seems to have a slightly higher rate of treatment-related adverse events. Both drugs can cause hepatotoxicity, and it's very important to monitor liver function tests frequently, every 3 or 4 weeks, based on the indications in the label of the corresponding drugs for both sotorasib and adagrasib. That's an important thing to note when we treat patients with KRAS G12C inhibitors. It is also very important, and I mention this to patients all the time, in a small percentage of patients treated with both sotorasib and adagrasib can develop pneumonitis, interstitial lung disease, and this is a potentially serious adverse event. So I always counsel my patients to report promptly if they experience shortness of breath, cough, chest pain, wheeze, anything to do with the chest. They should report this very quickly, and in those cases, what we will do is we will stop the drug and proceed with investigations to assess whether what is happening is pneumonitis or not.
Okay, I recognize that a lot of that G12C is much more common in lung cancer than it is the other types of cancer as well. Is that a typical side effect in the other types of cancers for colorectal, say pancreatic or whatever?
It is an excellent question, Terry, and you're absolutely right. The rate of both pneumonitis and liver tests and hepatotoxicity tends to be lower in other cancer types compared to lung. So it is something that everyone needs to be aware of, but at the same time, it's much more common and much more of a problem in patients with lung cancer treated with either sotorasib or adagrasib. So particularly patients with lung cancer need to be aware of this and promptly report, especially shortness of breath or chest-related symptoms. That's very important. Also important to know that adagrasib, there has been a report of prolongation of the QTc interval. That is an interval that we measure in the electrocardiogram. So patients treated with adagrasib need to have also careful monitoring of with frequent electrocardiograms, just to make sure that the drug is not causing prolongation of the QTc.
Okay, let me make sure. Okay, take a drink. You're like talking a million miles a minute. Take a quick sip. Okay, so all right, when you're talking about that, you're talking about like the heart side effects, right? And so
That's
monitoring our heart with like an EKG. Is that any different from these targeted therapies? Whether it's like lung cancer or is it just a targeted therapy thing, or is it just people that have been through different treatments?
Yeah, for QTc, it's people that have been through. It's not limited to lung cancer, so it depends. It can happen in any patient, and so patients that have got a history of heart disease, arrhythmias, or are taking other medications that can prolong the QTc interval. Some of the antiemetics fall into this category. It's important to provide a full list of your medication to your physician so that the physician can assess whether the G12C inhibitor might interact in any way with the other drugs that you are taking. And it is particularly important, especially when treated with adagrasib, to undergo an electrocardiogram, an EKG, both at baseline prior to starting treatment, but also while you're on treatment, to ensure that treatment with a drug does not lead to a prolongation of the QTc.
Okay. All right. Let me ask. Since I stopped you, let me just give a little bit more context. Okay. You know, we have 90 minutes, and I know you'll just keep going like gunfire, but and that's good. But okay. But from a practical standpoint, even if I'm taking, say, a nutritional supplement or Tylenol or something like that, I need to let my oncologist know this. And are all the oncologists, like, are they the be all, know all when it comes to this, or do I need to get, like, say, a pharmacist or something involved too?
Yeah, it's an excellent question. So usually in our practice as oncologists, we are supported by pharmacists. And most of the information regarding which drugs are allowed or which drugs might interact are included in the product, in the summary of product characteristics, in the documentation that exists and in the label. So we can look it up. But I think having a dedicated pharmacist that works close to the oncologist, or very, very frequently helps. I always run the lists of medications that my patients give me with my pharmacist, just to make sure, and they have the time and the expertise to go through each one of the drugs and make sure that there are no drug-drug interactions that might either reduce or otherwise affect the efficacy of the KRAS inhibitor, and more importantly, that there's no adverse interaction between the two drugs, for example, with regards to heart side effects such as QTc prolongation, etc. So very important to update your oncologist and generally your physician about what drugs you are taking, and particularly with adagrasib, you need to have also frequent electrocardiograms to make sure that this is not affecting in any way, shape, or form the QTc interval.
Okay, well, okay. So does that also apply to if you're on standardized, say, chemo or immunotherapy or any of these other types of treatments? Is that also something that we need to be watching for as a real life patient living with this stuff?
Yeah, typically for immunotherapy and chemotherapy, we don't routinely monitor the EKG. I think it's a good practice to always inform your oncologist about any changes in any medications that you might be taking, because they might be interacting with chemo or immunotherapy. But specifically for the heart, we don't normally do EKGs routinely, but we would always do an EKG if the patient is reporting symptoms that might be suggestive of cardiac problems. Both chemo and immunotherapy can rarely have adverse effects on the cardiovascular system. So if the patient is experiencing any symptoms, we would absolutely do it, but we don't normally do it routinely. Now with KRAS G12C inhibitors, especially adagrasib, you would need to have regular EKGs during treatment. Okay.
Thank you.
All right. So we spoke about the side effect profile, but what about patients that have got brain metastases? And this is another patient population that is very relevant. About 1 in 3 patients with metastatic KRAS G12C mutated non-small cell lung cancer will have brain metastases at baseline. So how does that affect our choice of a KRAS G12C inhibitor? We've seen data recently, both for sotorasib and adagrasib, the activity of the 2 approved G12C inhibitors in the central nervous system. And this is data regarding sotorasib. And these are patients that had brain metastases, but those were treated brain metastases. So this does not refer to brain metastases that had not been previously treated with radiation or surgery. And in this population, the intracranial activity of sotorasib, the ability of sotorasib to shrink intracranial metastasis was 13%. So 13% intracranial objective response rate. On the other hand, this is where adagrasib has much more robust data, because there were 2 studies presented, one in patients that had previously treated and stable brain metastasis. And in this patient population, adagrasib resulted in a 33% intracranial response rate, shrunk the metastasis in the brain in about a third of patients. But more importantly, for adagrasib, we also have more mature data regarding patients with untreated brain metastases. So these are metastases that have not been previously treated with radiation or surgery. And in this patient population, the intracranial objective response rate was 32%. So certainly for patients with brain metastases, the data regarding adagrasib are much more robust at this point in time. And this is a patient population where where I might favor using adagrasib over sotorasib, especially if the brain metastases are small in size and limited in number.
Okay, so let me just recover that. Just make sure I got it. Okay. All right. So intracranial means in my brain. Right,
Yes.
in my head. Okay. So if a brain metastasis, there's a little bit more data so far on adagrasib for G12C
That's
inhibitors
right.
versus sotorasib,
Mhm.
both of which are approved for G12C. Okay. But for right now, that's where we are.
That's right. So we're trying here to compare two drugs that are fairly similar, and we're trying to decide what might be scenarios where we would favor one versus the other. There is obviously no head-to-head comparison of these drugs. So here we're trying to discuss situations where I might favor one versus the other. So if someone had underlying heart disease, I might favor sotorasib because there I do not need to monitor the QTC and do EKGs. In someone with baseline brain metastases that are small, I might favor adagrasib because we've got more data up until this moment in time regarding the intracranial activity of adagrasib. We will get more data for sotorasib and its activity as we move forward, but right now this is the data that we've got. Okay. All right. So now we're moving into another part of the talk, and we are, and this is some of the research that I presented during, AACR here. We are trying to understand what are the molecular determinants of sotorasib and adagrasib efficacy. In other words, although sotorasib and adagrasib definitely have revolutionized the treatment of KRAS G12C mutated non-small cell lung cancer, for individual patients, the clinical outcomes are very variable. We've got some patients that do really well for a very long time with sotorasib or adagrasib with just one drug. We've got other patients where we treat them with sotorasib and adagrasib and their tumor grows fairly quickly. And up until now, we don't have a validated biomarker to select which patients benefit, have long-term benefit from KRAS G12C inhibitors versus patients that have worse clinical outcome and therefore might require a more intensive treatment approach, possibly a combination at an earlier point during their disease journey. So I would say that there are, broadly speaking, three major barriers to the efficacy of KRAS G12C inhibitor. The first barrier is what I refer to as the pervasive molecular diversity of the disease. That's a scientific term, but what does it mean in practice? In practice, it means that one patient's KRAS mutant tumor may behave very differently from another patient's KRAS mutant tumor. KRAS is not homogeneous, it's very heterogeneous. So what determines that heterogeneity? What makes one patient's tumor behave differently than another patient's KRAS mutant tumor? A number of things, but several years ago, we identified commutations as a major driver of this divergent behavior. What does commutations mean? Commutations means mutations in genes that happen together with KRAS, not in KRAS itself, but mutations in other genes, and these can be tumor suppressor genes or oncogenes that co-occur with KRAS and may influence the behavior of that tumor to therapy, okay? So commutations represent a major driver of the biological heterogeneity of the disease, and the biological heterogeneity of KRAS represents a barrier to the efficacy of KRAS G12C inhibitors. The second barrier, which is linked to the first barrier, is what I would refer to as rapid molecular adaptation. So in other words, in response to treatment with a KRAS G12C inhibitor, there is a response, but the tumor cells find a way to adapt to treatment with a KRAS G12C inhibitor. And there are multiple mechanisms that might explain how they adapt. One of them was discussed and analyzed and examined very elegantly and in depth by my colleague Piero Lito at Memorial Sloan Kettering Cancer Center, involves the synthesis, the generation of new KRAS molecules that get converted into an active KRAS, GTP-bound KRAS, and are unable to bind to the inhibitors, sotorasib and adagrasib. And more recently, we saw amplification of KRAS G12C. This means extra copies of the gene. Normally, we have 2 copies of KRAS, and one of them is going to be KRAS G12C when it is mutated. But cancer cells can amplify this KRAS G12C, and therefore make it more difficult for the drug to completely shut down KRAS signaling and exert its effect. So this rapid molecular adaptation is a mechanism that is a process that limits the efficacy of KRAS G12C inhibitors. And it's also, from a scientific perspective, it's interesting to ask the question whether there is a link between the different commutations and the mechanisms that the cancer cell uses to adapt to KRAS G12C inhibitors. So these two barriers might be linked. So what do we know about the efficacy, what do we know about the impact of commutations so far on the efficacy of KRAS G12C inhibitors? Well, this is data from the CodeBreak 100 phase 2 study for sotorasib and the Crystal-1 study for adagrasib. And here we are looking at the objective response rate to either sotorasib at the top or adagrasib at the bottom, depending on commutations. And what you can begin to see is that patients that had commutations in a gene called KEAP1 appear to have a lower chance of achieving an objective response with sotorasib. You can see here 14% compared to 39% in the entire patient population. And the same here with adagrasib. The objective response rate for patients whose tumor has got a KEAP1 commutation is only 17% compared to 55.9% in patients that do not have these commutations. However, in these studies, the numbers of patients were limited. And as you can see, the confidence intervals are wide. So this makes it difficult to derive any definitive conclusions based on these studies regarding the impact of commutations. So in order to address this problem, we decided to conduct a much larger retrospective study to try to really nail down the potential impact of all these commutations on clinical outcomes with KRAS G12C inhibitors, sotorasib and adagrasib. We collected data and analyzed data from 424 patients with metastatic KRAS G12C mutated non-small cell lung cancer that were treated across 21 academic centers in North America and Europe. This is by far the largest study to date. It's much larger than the randomized controlled clinical trials, and it is truly an international study conducted across 2 continents, North America and Europe. So we analyzed the data, and this is the initial conclusions regarding the efficacy of sotorasib and adagrasib in our patient population. So the objective response rate in our cohort was 34%. So you can see that this is very similar to what has been reported regarding the efficacy of sotorasib and adagrasib in the registrational studies. This gives us confidence that our cohort is representative of the true patient population. And you can see there that the median progression-free survival was 5.2 months, and the median overall survival was 10.7 months. So these numbers are again on par with what has been reported previously regarding the efficacy of sotorasib and adagrasib. This is perhaps one of the most important conclusions. So we asked the question, if we compare patients that are treated with sotorasib and adagrasib, but have got widely different clinical outcomes, distinct clinical outcomes. And by that, I mean patients that either have early disease progression, and we define here early disease progression as a progression-free survival of less than or equal to 3 months. So patients that started treatment and their disease progressed within 3 months, versus patients that had long-term disease control. And here we define long-term disease control as progression-free survival of 6 months or more. So we're comparing these 2 groups of patients with very different trajectories when treated with sotorasib and adagrasib. And we're asking the question, are there commutations that are significantly enriched, significantly more likely to be found in one versus the other group of patients? And when we do that analysis, we found 4 genes that were enriched, that were much more frequently seen in the group of patients with early disease progression. These were KEAP1, SMARCA4, CDKN2A, and STK11. So we had our candidates, and then we went and looked at the impact of each one of these genes on clinical outcomes with KRAS G12C inhibitors. So here we're focusing on KEAP1. And you can see we are comparing the progression-free survival and overall survival with sotorasib and adagrasib in patients. All patients here have got a KRAS G12C mutation, and we are separating into those that have a wild type for KEAP1, that's the blue line, versus the one that have got a commutation in KEAP1. That is the red line. And you can very clearly see that patients that have tumors with commutations in KEAP1 had much shorter progression-free survival compared to tumors that did not have a commutation in KEAP1. So the median was 2.8 months compared to, so you can see 2.8 months compared to 5.4 months. And the hazard ratio here, which corresponds to the risk of progression or death, 2.26. So much more likely to experience disease progression sooner with G12C inhibitors. Similar conclusions when we looked at overall survival. This is, of course, how long patients live. And you can see here that the median overall survival was 6.3 months in patients that had a commutation in KEAP1 and 11.1 months in patients that did not have a commutation in KEAP1. When we looked at the objective response rate was 22% in patients with a KEAP1 commutation, 34.8% in patients that were wild type for KEAP1. So having a commutation in KEAP1 clearly adversely affects outcomes with when a patient is treated with sotorasib or adagrasib. Okay.
I'm going to want to make sure I follow
Yes.
all of that. So, all right. So I'm going to just tell you, take a sip and let me see if I've got this. Okay. So this was all based on, this was a retrospective study. So it was based on patients that had already been through this. This wasn't like some sort of thing that's set up, right? And so all these patients were already they were all G12C patients. They were all non-small cell lung cancer patients. And you were trying to identify and drill down into the data to see who did better and who did worse, and see if there was any sort of continuity to what that was. And it turned out this STK11, the KEAP1 were two of the big indicators as far as some people that had a tendency to do worse on G12C inhibitors than the other ones. Am I tracking?
Yes, we found 4 genes. Actually, the 3 ones that were associated with worse outcomes were KEAP1, SMARCA4, CDKN2A. STK11 came up in that analysis, but I will show you exactly what happens with STK11 in a minute. Okay, and that is quite surprising.
I just want to make sure that we're all on the same page. And then because what we'll do, okay, a lot of us are going to pick up our reports, and if we're in G12C inhibitor, we're going to look and see, okay? And so just to reiterate, okay, WT, which is you'll see on your reports a lot of times, means wild type, and wild type is not the mutated type.
That's right.
Okay.
So your report is not going to say that you're wild type. It is only going to report if you have a mutation. So the report is going to say KRAS G12C, and then underneath it will show multiple other genes. And then we look at the list of those genes and we see whether we can find mutations in KEAP1, SMARCA4, or CDKN2A. Those would be associated with a higher chance of the tumor not responding well to sotorasib or adagrasib. It wouldn't say whether you're wild type. If you don't see the mutation, you can assume that it was not detected. Therefore, the tumor is wild type. Absolutely. Okay. All right. So we're moving forward now to the second gene. We said 3 genes, KEAP1, SMARCA4, CDKN2A. So what is the impact of SMARCA4 co-alterations? SMARCA4 seems to be one of the most potent drivers of worse outcomes. So it's one of the most of the genes that are really associated with poor responses to KRAS G12C inhibitors. So you can see here that the median progression-free survival in patients that had the mutation in SMARCA4 was 1.6 months compared to 5.4 months in patients that did not have the mutation. And the median overall survival was 4.9 months compared to 11.8 months. So very big difference in patients that either did or didn't have the mutation. Interestingly, when we just compare the objective response rate, that's the chance of the tumor shrinking, we didn't find a difference between SMARCA4 mutant and SMARCA4 wild type. So therefore, this suggests that just comparing the objective response rate doesn't really capture the adverse effect of SMARCA4 alterations on the clinical efficacy. So these are typically patients that may have a response at the first scan, but then after that first scan, the tumor quickly develops disease progression. But this is an important point to make. SMARCA4 is one of the most is one of those commutations that are associated with worse clinical outcomes in patients treated with sotorasib and adagrasib. And this is now our third gene, CDKN2A. This is a gene involved in the regulation of cell cycle progression. And again, similar to what we saw previously about KEAP1 and SMARCA4, mutations in CDKN2A are associated with worse outcomes. Median progression-free survival is 3.4 months compared to 5.3 months. And median overall survival is 6.4 months compared to 10.7 months. So again, this is the third gene that is associated with worse clinical outcomes. Now, this is your question, Terry. What about STK11? And we are particularly interested in STK11 because STK11 is one of the most commonly commutated genes. Up to 1 in 3 patients with KRAS G12C mutant non-small cell lung cancer, if you look at your report, and your report covers an extensive panel of genes, you will find an STK11 commutation. So this is something that we see quite frequently. And also STK11 mutations have been previously associated with worse outcomes with particularly immunotherapy containing therapy. So it was very important to assess how do STK11 mutations impact responses and clinical outcomes with sotorasib and adagrasib. When we looked at all STK11 mutations, regardless of what else was found in that report, in that tumor, it seemed that STK11 was indeed associated with slightly worse clinical outcomes. However, we looked at that in much more detail. So what we did here is we tried to separate the impact of STK11 mutations from mutations in KEAP1, because KEAP1 and STK11 mutations very frequently co-occur in the same patient. So you can have not only STK11 in your report, but KEAP1 as well. This happens quite quickly. It happens quite frequently. And because we had already shown that KEAP1 is associated with worse outcomes, we wanted to see whether STK11 was associated with worse outcomes when it is found on its own, without KEAP1 in the same tumor. Okay, so we tried to separate the effect of STK11 from KEAP1. And what we found is that STK11 alterations on their own do not appear to impact clinical outcomes with sotorasib and adagrasib in the absence of concurrent KEAP1 mutations. So look at this here. These are the curves. So the blue is the curve corresponding to patients that have no mutation in STK11 and no mutation in KEAP. So these are the patients that are wild type for both genes. And here we are comparing it with the green. The green corresponds to patients that have got mutations only in STK11, but not in KEAP. And you can see that they are completely overlapping. So there is no difference in outcome in patients with STK11 mutations when KEAP1 is not mutated. The red curve is what corresponds to patients that have got mutations in KEAP1. So it's really KEAP1 that is associated with worse outcomes, not STK11. And this is an important conclusion. If your report shows KEAP1, if your report shows STK11 mutation together with KRAS G12C, but no KEAP1 mutation, then that is a good thing. It means that the outcomes are expected to be the same as those patients that don't have a mutation in either STK11 or KEAP1. It's really KEAP1, SMARCA4, and CDKN2A that are the bad players here. STK11 on its own does not appear to adversely affect outcomes with KRAS G12C inhibitors. Very important conclusion, because STK11 is something that we very frequently see together with KRAS G12C. Any questions on this point?
Thank you for allowing me that. Yeah. Yes. Okay. So I want to make sure I'm following. So STK11 in and of itself is not the biggest bad player. Okay. It's really when you have the combination of the STK11 in addition to the KEAP1.
It's actually the KEAP1 alone, whether it has STK11 or not.
Okay. So really it's the KEAP1 that's really
it's the KEAP1. That's right. That's right.
All right. So as the KEAP1 is the bigger troublemaker. Now, is that that is only for the G12C inhibitors, or was this drilled down for immunotherapies and chemos as well?
That's an excellent question. No, this study focused solely on G12C inhibitors, but there is mounting data from multiple clinical trials, large clinical trials, looking at the impact of these genes on outcomes with different immunotherapies. So one of the most important conclusions that we are coming towards, and this is data from the Poseidon clinical study with chemotherapy, as well as durvalumab and tremelimumab, what we are learning is that patients with STK11 alterations, but particularly patients with KEAP1 alterations, seem to really benefit from the addition of anti-CTLA-4 treatments, such as tremelimumab, to their chemoimmunotherapy regimen. So when we have chemoimmunotherapy, we have a number of approved regimens, right? We've got the Keynote 189 regimen, which is a combination of platinum chemotherapy with pembrolizumab. We've got several chemoimmunotherapy regimens that include anti-PD-1 or anti-PD-L1, but there are now a number of chemoimmunotherapy regimens that are approved that also include anti-CTLA-4. The two of them are the 9LA regimen, which is a platinum doublet chemotherapy plus ipilimumab and nivolumab. And there is the second one, which is the Poseidon regimen, which is platinum doublet chemotherapy with durvalumab and tremelimumab. And the emerging data suggests that patients with STK11 and KEAP1 really derive selective benefit more from the addition of CTLA-4 to their chemoimmunotherapy regimen. So I am currently treating, when a patient appears in front of me with an STK11 or a KEAP1 alteration, regardless of the KRAS G12C mutation in the first line setting, I would very frequently select one of those two regimens. Most recently, I've been using the Poseidon regimen, which is chemotherapy plus durvalumab plus tremelimumab to treat those patients. Okay, so this is important because CTLA-4.
Okay, and those are it's just a type of treatment as opposed to like a platinum-based chemo. That's all.
It's an immunotherapy. It tackles a different checkpoint. So durvalumab or pembrolizumab, they tackle the PD-1, PD-L1 axis. CTLA-4 tackles a different checkpoint. So it's an enhanced form of immunotherapy that seems to particularly work in this patient population. One of the questions that we've got in the field is which patients benefit from the addition of CTLA-4, because these CTLA-4 containing regimens are more intensive. Frequently, they have more side effects than regimens that only include one immune checkpoint inhibitor, like a PD-1 or PD-L1. So for which patients should we be reserving or using this more intensive approach? And our data, data that is emerging across a number of different studies, suggests that patients with STK11 or KEAP1 alterations, particularly KEAP, seem to benefit more from the addition of CTLA-4 to their first-line regimen. Okay, so that is an important question.
To wrap that into a little bundle, okay, you're saying if you have those, even if you don't have a G12C, it's very possible that may be a better treatment source.
First line treatment for sure. Yes. Yes, okay, I use it. At least that's my practice.
Not everybody has the benefits of seeing you guys, right? Okay. So I mean, you try and have a life outside of work, right? But okay, but so it's important that's one of the big takeaways, because we benefit across the world as a result of hearing this sort of information. Okay, and so it's going to be boiling down into these co-mutations. The KRAS is part of it, but it's also going to be the co-mutations as well. And we may be looking at doing better with the CTLA-4
in the first line setting. Yes. Right now, the G12C inhibitors are not approved in the first line setting. They're approved in the second line setting. But certainly, if I see a patient with a metastatic lung cancer with an STK11 or KEAP1 alteration, regardless of KRAS, certainly in the context of KRAS, but even without KRAS, one of my probably most preferred regimen right now is the Poseidon regimen or the 9LA regimen. So to incorporate CTLA-4 blockade.
Now, I know you're a lung cancer doctor, but is that what's happening also in colorectal as well? Or if you don't know, that's okay.
It's kind of quite different in colorectal because not all patients with colorectal cancer benefit from immunotherapy. It's really only patients with mismatch repair deficient colorectal cancer that benefit from immunotherapy. So that is a little bit different in colorectal cancer. This applies to lung, and it's a little bit different in colorectal cancer. Also, the commutations that occur with KRAS in colorectal cancer are quite different because colorectal cancer doesn't have STK11 mutations or KEAP1 alterations quite frequently. It frequently has mutations in Wnt pathway genes because the Wnt pathway is what really drives colorectal cancer, such as APC or beta-catenin. So the commutational context is quite different in colorectal and pancreatic than it is in lung. It's really lung where we have seen the most profound impact of these diverse co-alterations that we're discussing today.
Thank you.
All right. Okay. So what about, so the three genes that I spoke about, STK11, or the four genes, but the three that are associated with worse outcomes, SMARCA4, KEAP1, and CDKN2A, are, if you want, the major players. But because of the size of our analysis, we were even able to drill down into less common, less prevalent alterations that might also be affecting outcomes with KRAS G12C inhibitors. So we found a number. This was an exploratory analysis. Here the numbers are much smaller, so definitely requires validation in further studies. But some of the interesting signals that we observed here is that baseline alterations in RAS genes, in addition to the KRAS G12C, so KRAS G12C plus other alterations in RAS genes, and this can involve NRAS mutations, HRAS mutations, as well as amplifications of KRAS, multiple copies of the abnormal gene, may also be associated with worse outcomes with KRAS G12C inhibitors. And this is relevant because some of these alterations may well be targetable with some of the broader acting KRAS inhibitors that are coming into clinical development, such as the pan-RAS inhibitors, or the inhibitors that are active against RAS-on, the GTP-bound form of KRAS. So this is an important additional conclusion. We also found that mutations in genes involved in the PI3K/AKT/mTOR pathway may also be drivers of resistance to KRAS inhibitors. And this is also relevant because we have drugs that inhibit different components of the PI3K/AKT/mTOR pathway. So this may provide the optimal ground for tailored combination therapeutic strategies. And finally, before I move into this, we also found some genes that might be associated with better outcomes than with KRAS G12C inhibitors, such as mutations in DNA repair genes. This is something that, again, requires further validation, but we have found basically genes that affect clinical outcomes, both in a bad way, but also in a potentially in a positive way. How do we integrate all these findings that I have discussed with you? This is one of the most important slides, certainly from our work. So we identified these three genes, KEAP1, SMARCA4, CDKN2A. Let's bring them all together and assess all of these genes together. When we do that, we capture approximately 1 in 3 patients with KRAS G12C mutated non-small cell lung cancer. So 32% of all patients with KRAS G12C will have one or more of those 3 co-alterations. So we're capturing about a third of the entire population. And these 3 genes, on their own or in different combinations, may account for up to half, up to 50% of all patients that exhibit early disease progression with a KRAS G12C inhibitor. So when we look at all patients that don't do so well, and their disease progresses within 3 months of starting therapy, about 1 in 2 of those patients will have a mutation in 1 or more of these 3 genes that I outlined. So these 3 genes clearly account for a very large proportion, about half, of all patients that exhibit early disease progression with KRAS G12C inhibitors. And when we put these 3 genes together and we look at the clinical outcomes, these three genes, knowledge of the status of those three genes clearly separates patients into groups with very different trajectories, very different outcomes. So you can see that the median progression-free survival for patients with a mutation in any of the three genes is 2.8 months compared to 5.9 months for patients that are wild type for all the three genes. Even more impressive, look at the median overall survival. So patients that have a mutation in one of those three genes have got a median overall survival of 6.9 months compared to 13 months for patients that don't have a mutation in any of those three genes. So clearly, knowledge of the genetic status of these three genes allows us to separate patients into groups with completely different prognosis, completely different outcomes with KRAS G12C inhibitors. And why is this important? This is important first for patient stratification, because when we're assessing a new drug, we want to make sure that patients are equally distributed. Otherwise, you might not assess the impact, you might not accurately assess the impact of a new drug. But for an individual patient, even more importantly, knowledge of these commutations may identify those patients that really need a more intensified treatment approach with perhaps with a combination of a G12C inhibitor with another agent or with a novel strategy altogether. This helps us understand which patients do really well with sotorasib or adagrasib alone versus those that we suspect they're not going to do very well and therefore might require a more intensive or a more personalized treatment approach from the outset. Any questions there?
Thank you for giving me space. Yes. Okay. So first of all, I want to make sure that I understand. So because we don't control what commutations we do or do not have.
That's right.
And so it is what it is. And this is just how you're making a decision as far as what our best treatment options may potentially be, right? And what kind of like your strategic analysis as far as what we may or may not benefit from.
That's right.
So as a result of this information, the commutations would lead you to be much more aggressive upfront. As a result am I tracking with you?
Absolutely. If you have one of those three commutations, you know that just sotorasib or adagrasib, you're unlikely to achieve long-term disease control. And therefore, that's the patient that I would prioritize or I would really urge or try to find a clinical trial for. And also, because I know the commutations, it might also help me select which clinical trial might be the most appropriate fit for that patient, depending on the individual commutation. So it's important for two reasons. One, to separate the patients that do very well from the ones that don't do so well and require a more intensive approach, and also to select the most appropriate clinical trial for an individual patient.
Okay, so it's in the strategic planning and the analysis of what's going to be happening. And it's not necessarily like this is what's going to happen, but this is just what the data is showing overall over the course of what is typical, right?
Absolutely, absolutely. Okay. And there are always exceptions.
But it tells us also that now, is there any sort of indication as far as what acquired resistance there is as a result of these different commutations? Is there anything that's leading in that direction, or is that like even to the next step again?
That is an excellent question. I think my next slide is about acquired resistance, but that is an excellent question, Terry. So this is the slide on acquired resistance, and this is, remember at the beginning I said that there are three hurdles, that there are three impediments, if you want, to the efficacy of KRAS inhibitors. We said the heterogeneity is number one, early disease adaptation is number two, acquired resistance is number three. What does acquired resistance mean? Acquired resistance means resistance after an initial period of response. So this is a little bit different than the impact of the commutations that I referred, because that is early disease progression. So really the tumor either does not respond at all or adapts very quickly after initial response. And here it's acquired resistance usually refers to patients that have responded for a bit of time and then they stop responding, the tumor starts to grow. And this is where we have data from both Dr. Awad's group, this is from 2021, this excellent New England paper, as well as from the Memorial Sloan Kettering, Piero Lito and Bobby Lee. And the conclusion in both cases is that acquired resistance is challenging to overcome. Why? Because first of all, we don't see a single mechanism of resistance that we could focus on. We see multiple mechanisms of resistance that are quite diverse and quite frequently co-occur in the same patient. So a single patient can have multiple different resistant clones that contribute to clinical progression. Broadly speaking, three mechanisms of resistance. One is additional mutations in KRAS, secondary mutations in KRAS itself. This is what we call on-target resistance. For example, you can acquire a mutation that prevents sotorasib or adagrasib from binding to its target, or you can acquire an additional KRAS mutation that is insensitive to inhibition, such as a G12D or a G12V mutation.
Does this happen also in like EGFR and other targeted types therapies, or is this?
Yes, absolutely. So it absolutely happens in the EGFR and other targeted therapies. But for EGFR, for many, many years, at least with the first and second generation inhibitors, such as erlotinib and gefitinib, the landscape of acquired resistance was very different because we had a dominant mutation. It was called, for EGFR, it was called T790M. That you could find in up to 50 to 60% of all patients that developed acquired resistance to gefitinib or erlotinib. So there, the pattern of acquired resistance was more uniform. We had 50 to 60% of patients this one mutation that we could then target with the third generation inhibitors, such as osimertinib. Okay, now that osimertinib is the standard first line treatment for patients with classical EGFR mutations, we are beginning to see a little bit more of what we are observing for KRAS inhibitors. In other words, multiple different independent, on-target resistance, bypass track signaling, but also a problem that I think we will also increasingly encounter in the KRAS field, which is what is referred to as plasticity or histological transformation. In other words, a tumor that starts by being an adenocarcinoma, and at the time of progression, when you rebiopsy the tumor, it has changed from being an adenocarcinoma into being either a squamous cell carcinoma. This is what was observed in Dr. Awad's study, or in, as has been observed in the EGFR field, very frequently they observe histological transformation to even more aggressive types of lung cancer, such as small cell lung cancer, which the non-small cell can convert into small cell at the time of acquired resistance, which is something that I expect we will also see in the KRAS field as the inhibitors become more and more potent and as we move towards the future. So there are a number of unanswered questions and challenges with regards to acquired resistance. One of the questions you already asked yourself, Terri, as we were going through the previous one, which is, does the baseline status of the tumor before we start treatment predispose to a particular type of resistance? Can we predict what type of resistance, what mechanisms of resistance will develop in an individual patient based on knowledge that we can gather at baseline? And this can be commutations. It can also be additional parameters that we have not yet worked out. But that is an important question. Is the emergence of resistance a stochastic or random event? Or is it in some way or form predetermined or engraved in the tumor, and we can therefore predict it? It would be great if we could predict what mechanisms of resistance an individual patient would develop, because then we could forestall it, we could prevent it, which is the best way of dealing with it. The second question that I think is an important question in the field is, what is the real significance of what I refer to as polyclonal resistance? So very frequently I'll see a patient and we'll do a liquid biopsy at the time of resistance. And as I mentioned, they will not just have a single alteration, they will have maybe 10 different potential mechanisms of resistance, each one present in a small fraction of cancer cells. So the real question there is, what is the real significance of this? Is it that all of these mutations are contributing to resistance, or is one of them dominant and really driving the disease progression in that individual patient? Those are areas that I think require further investigation, and I know that many of us are actively engaged in these types of studies to try to understand the significance of polyclonal resistance, because it really, at least conceptually, represents a major problem. How do we? It's easy to tackle one mechanism of resistance. We can find drugs that work against that protein, but if we have 10 different mechanisms of resistance in the same patient, or potential mechanisms of resistance, how do we decide what drug to use, and how can we ensure that that approach is going to tackle all those resistant clones? So that is an important and as yet unresolved question in the field.
Okay,
it's
can
also
I add one more thing about that? But so that's really starting to tell how much more important it is for us to get a biopsy, whether it's a liquid biopsy or pathology on our tumor, to see if there's been any sort of mutations.
Absolutely. First of all, I think it's important to have knowledge of a broad panel of genes. I mean, you've seen the data on commutations. Clearly, they affect outcomes. So it's not just all about knowing that you're KRAS G12C mutant. We want to know what other mutations that tumor might include. And at the time of resistance, very important to sequence again to see what is driving acquired resistance in an individual patient. Sorry, Steve is raising his hand.
Yes, thank you, Doctor. I had a question about these commutations, like CDKN2A and KEAP and the SMARC. And my question is there research that indicates that these sort of differences in progression-free survival pertain to other variants of KRAS, for example, the other G12s and G13s and so on, whether or not this is whether there's been research showing that, or it's just been at this point on that?
Yeah, it's an excellent question, Steve. And it's very interesting that for some of these alterations, they have been picked up in CRISPR screens. They have been picked up in vitro. CRISPR screens are screens where you en masse knock out different tumor suppressor genes at the same time as treating with a G12C inhibitor. And you look at which of these alterations promote growth of tumor cells under the selective pressure applied by drug. So in short answer to your question, there is strong preclinical data to suggest that many of these, in particular KEAP1, likely also CDKN2A, are more general drivers of insensitivity or partial sensitivity to G12C inhibitors, not just in a G12C setting, but also in the context of other KRAS mutant alleles. Of course, the baseline prevalence of these commutations is very different, as I explained, in lung cancer compared to colorectal or pancreatic cancer. We see far more frequently KEAP1 mutations in lung cancer than we see in colorectal or pancreas. But definitely, at least in vitro and in animal models, when you inactivate that protein, you can induce partial insensitivity to the KRAS targeted therapy, be it a G12C inhibitor or a G12D inhibitor, or even some of the more advanced inhibitors that are coming into clinical development. Okay.
Thank you.
Absolutely. So this is the final slide on resistance, and then we're going to move into, because there's still a lot of stuff that I want to tell you about new therapeutics. So it's important also to recognize that genetic mechanisms of resistance, commutations or acquired mutations clearly are not going to be the only player here. And it's important to identify non-genetic mechanisms of resistance. In other words, in up to 50% of patients currently at the time of resistance, we cannot detect a new mutation that might be triggering or that might be mediating the resistance. And it's very important to go down, obtain biopsies from these patients and look at the composition of the tumor microenvironment to try to understand, does the tumor microenvironment, be it the immune component of the tumor microenvironment or the non-immune component of the tumor microenvironment, such as the fibroblasts that are there, or different types of cells, how they might be contributing to acquired resistance to KRAS G12C inhibitors. So this is a very interesting area of study, because one of the potential mechanisms through which we can overcome resistance to KRAS G12C inhibitors might not necessarily be with drugs that target the tumor cell itself, but it might be with drugs that modulate the composition of the tumor microenvironment, especially the immune component of the tumor microenvironment. So it's really important to drill down on this and try to understand the non-genetic mechanisms that contribute to resistance to KRAS G12C inhibitors. Okay, all right, we're moving on. How do we tackle these challenges? What can we do for patients that do not derive as much benefit with KRAS G12C inhibitor monotherapy, or what can we do in general to try to maximize the efficacy of KRAS G12C inhibitors? So combinations are one of the natural things that we always do in oncology. We combine more than one drugs, and we hope that those drugs are going to be additive or even better, synergistic. In other words, one of the drugs will facilitate and enhance the action of the other drug. So as expected, multiple companies that are developing KRAS inhibitors are testing different combinations. And broadly speaking, there are three types of combinations that are being assessed. One, combinations with chemotherapy, the standard of care. Two, combinations with immunotherapy, which are again the standard of care, especially in the treatment of non-small cell lung cancer, and also targeted therapies that may act either upstream or downstream of KRAS in the MAP kinase signaling pathway, as well as drugs that might act not vertically, but in parallel signaling pathways, such as the PI3K AKT pathway. And there are multiple combinations. I am going to highlight a few, which including some of the new data that was presented in this year's AACR. So one of the combinations that are very rational and we're quite excited about is combining KRAS G12C inhibitors with inhibitors of EGFR. And there are multiple ways to target EGFR, including tyrosine kinase inhibitors. Last year, I think we saw some preliminary data from the combination of sotorasib with afatinib, which is a pan-HER family inhibitor. And that study showed some efficacy, but there was also concerns about toxicity. But more recently, we have seen favorable results by combining KRAS G12C inhibitors with monoclonal antibodies that target EGFR, such as cetuximab. So in this study that was published in the New England Journal of Medicine, really impressive results, because this is in colorectal cancer patients. So you can see there that the efficacy of adagrasib monotherapy, so when you're just using adagrasib on its own, the objective response rate is 19%. The median duration of response is 4.3 months. The median progression-free survival is 5.6 months. When we add cetuximab, and we combine adagrasib with cetuximab, the objective response rate goes from 19% to 46%, so more than doubles. So this is very impressive results from the combination of an EGFR targeting monoclonal antibody with adagrasib. And you can see here that the median duration of response is 7.6 months, median progression-free survival 6.9 months. This is data that was presented at AACR, and this is data that I'm quite excited about. So this was the combination of GDC6036, which is the KRAS G12C inhibitor from Genentech Roche, again in combination with cetuximab in advanced colorectal cancer. So first of all, the combination was, broadly speaking, quite safe. 10.3% of patients did have grade 3 diarrhea, but this is a common side effect attributable that can occur both with G12C inhibitors as well as cetuximab. So no new safety signals were observed, and overall the toxicities were expected and manageable. But look at the reported efficacy. I think that these are very impressive results. So remember the monotherapy, the activity of GDC6036 on its own in colorectal cancer that we spoke about at the beginning of the talk was as high as 36%, 32 to 36%. But when we add cetuximab to GDC6036, the confirmed objective response rate goes as high as 62%. This is very impressive. So these are certainly numbers that we have not seen previously for G12C inhibitors certainly in the context of colorectal cancer, where the activity of G12C inhibitor monotherapy is generally reduced compared to what we observe in non-small cell lung cancer. So we're eagerly awaiting more data on this combination regarding progression-free survival, overall survival, but I think the data that was presenting at this year's AACR with a confirmed objective response rate of 62% is certainly quite impressive in my opinion. We also saw data from the other KRAS G12C inhibitor, Lilly's compound, so LY3537982, also in combination with cetuximab. This was cohort C2 of their clinical trial. And again, the combination was overall reasonably well tolerated. There were no unexpected safety signals. Now, in this analysis, the objective response rate, the overall response rate with LY plus cetuximab was 45%, with a disease control rate of 100%. So I think across a number of different studies, we are beginning to see that the addition of cetuximab or EGFR targeting monoclonal antibodies, such as cetuximab or panitumumab, is clearly associated with improved efficacy compared to KRAS G12C inhibitor monotherapy in colorectal cancer. And certainly the levels of efficacy that we are observing are quite noticeable and in my opinion, impressive. Okay. This was not presented at AACR, but this is also an interesting class of agents that is being combined with G12C inhibitors, and these are the SHP2 inhibitors. SHP2 is a phosphatase that lies upstream and controls multiple steps in pathway activation upstream of RAS. Now, SHP2 inhibitors have been somehow difficult to combine with G12C inhibitors in clinical practice because of treatment-related adverse events, and I think still there are challenges with many compounds. But I think there is at least some room for optimism there. This is the data that was presented last summer with sotorasib plus RMC-4630. That showed preliminary evidence of efficacy with a 50% objective response rate in patients with that were KRAS G12C inhibitor naive and had metastatic non-small cell lung cancer. We'll have to see more regarding the combination of SHP2 inhibitors with KRAS G12C inhibitors to really understand and clarify whether there is a therapeutic window for use of these agents, especially when combined with other possible drugs. Okay, so I want to spend a little bit of time on talking about the combinations of KRAS G12C inhibitors with immunotherapy. This is very important for a number of reasons. First of all, because at least in non-small cell lung cancer, immunotherapy is a cornerstone of the first-line treatment of metastatic non-small cell lung cancer. Therefore, it is inevitable that we need to assess the impact of G12C inhibitors on the combination of G12C inhibitors with immune checkpoint inhibitors. But also mechanistically, at least in animal models, there is very clear evidence that there is synergy, that at least some of the efficacy of the KRAS inhibitors is mediated by the immune system. And one of the experiments, one of the data that I like to show is here. When you take the CT26 colorectal cancer model and you implant it in an immune deficient animal and you treat the animals with sotorasib, you can see that initially the tumor shrinks, but afterwards, in all cases, the tumor recurs. So there are no mice that are cured when the immune system is deficient. When you do the same experiment using the same model in an immune competent animal, in an animal that has got an intact immune system, this is where you start to see cures in a fraction of the mice. This suggests that at least part of the efficacy of KRAS G12C inhibitors is mediated via activation of both the innate and the adaptive branches of the immune system, that our immune system contributes to the efficacy of these drugs. And here, at least in preclinical models, you can see that sotorasib synergizes with anti-PD-1 to induce cures in the majority of treated mice. These are also tumors from these mice where you can see that when you combine AMG 510, this is sotorasib, with anti-PD-1, you increase significantly the number of tumor infiltrating lymphocytes. These are the CD8 lymphocytes that attack and kill tumors. Okay. But one important question, and this is some data was presented in this conference from Julian Downward's lab. This is an important question. Do all patients benefit from the combinations of KRAS inhibitors and anti-PD-L1? And the answer is probably no. We don't know that for sure yet, but at least the emerging data suggests that this combination works best in tumors that have got high intrinsic immunogenicity. So these are the tumors with high PD-L1 tumor proportion score. That might be the group of patients that benefits most from the combination of an immune checkpoint inhibitor and the KRAS inhibitor. On the other hand, animal models that don't have a lot of lymphocytes to start with, are immune cold, may not really benefit that much from the addition of a KRAS G12C inhibitor with a PD-1 inhibitor. And why is this important? This is important because, at least with the data that we've got so far, there are some challenges to the combination of G12C inhibitors with immune checkpoint inhibitors. So this is data from the Codebreak 100 and 101 studies where sotorasib was combined with either atezolizumab or pembrolizumab at various doses and 2 different schedules of administration. And the conclusion was that the combination resulted in a significant rate of treatment-related adverse events, most notably hepatotoxicity. So it is not completely straightforward to combine immune checkpoint inhibitors with KRAS G12C inhibitors. Even in cases, this is data from Crystal 7, where adagrasib was combined with pembrolizumab. Now, adagrasib appears to be, does not result in the same rate of hepatotoxicity, of immune-related adverse events when combined with pembrolizumab. So this combination was feasible. However, even in cases where you can safely combine a KRAS G12C inhibitor such as adagrasib with an immune checkpoint inhibitor such as pembrolizumab, it may not be that all patients benefit to the same extent. You can see here that patients that had a PD-L1 tumor proportion score of less than 1, these are the PD-L1 negative tumors. Here, the objective response rate was 30%, which is not that different from the efficacy of adagrasib on its own there. So it may be we need to really start thinking about selecting the most appropriate combination of a G12C inhibitor with either chemo or a PD-1 inhibitor, depending on our knowledge regarding the likelihood of achieving synergy when you combine those two together. I'm going to pause for a minute because I can see you've got questions there.
What did you see? I'm ready to explode over here on my.
Yes, I am. Yes, I saw you ready to explode.
Okay. Yeah, we don't want to have that. Okay, not on screen. Okay, I'm like looking at the clock. I see we have like 5 minutes left.
Okay.
And this is super fascinating, but I know that there was like other stuff that happened too, besides like the G12C.
Yes.
And everybody is sitting on the other side of the screen is thinking, what about me?
Yes.
And so
we're going to go through it.
Yeah. Okay. And and G12C is small and okay. So I'm trying to manage the clock as it is, right? Okay.
All right. Okay. So we're going to go through the rest. Okay. So this is just one additional study regarding the LY compound together with pembrolizumab. This is again showing promising results, but we have to see more regarding safety. Okay, I'm going to go straight to non-G12C and novel approaches to target KRAS mutant tumors. I am going to focus on a couple of things that I thought were very, very interesting. So these are a different class of compounds. These are the RAS-on tricomplex inhibitors from Revolution Medicines. And this is really a completely novel approach to target KRAS mutant tumors based on the formation of a ternary complex. You can see here that the RAS-on inhibitor binds to cyclophilin. It forms a binary complex, and then that binary complex can bind to RAS and inhibit it. And Revolution Medicines have been developing both mutant selective inhibitors. So here you've got their own inhibitor that targets KRAS G12C, 6291. But also more importantly, they've developed compounds that can bind to multiple different mutant versions of KRAS. So if we've got the RAS multi-on inhibitor that you can see doesn't only target G12C, it can target G12V, G12R, G12D, and multiple different kind of mutations. So this is very impressive data that was released ahead of the AACR meeting, but I want to highlight it here. This is from the phase 1 study of RMC 6236001. So this is the RAS multi-on inhibitor. This is the one that can target multiple different KRAS alleles. So quite interestingly, this compound, there were some concerns before the study about whether targeting KRAS, HRAS, and NRAS simultaneously would result in toxicity. We do not appear to be seeing that up until this moment in time. This combination, this drug appears to be fairly safe with, as you can see here, no grade 3 treatment-related adverse events. So this is very exciting data and something that I think the field has been eagerly awaited. Using a pan-RAS inhibitor, or RAS multi, as it's called, that targets the on state of KRAS, appears to be well tolerated. And this is the preliminary data that they showed regarding the efficacy. So you can see here we've got an unconfirmed partial response in a patient with pancreatic ductal adenocarcinoma with a KRAS G12D mutation. And we've also got a response in a patient with metastatic non-small cell lung cancer and a G12D mutation. Overall, we saw shrinkage or stabilization in most of the patients that were treated on this study. So this is very exciting data. It's preliminary, of course, but it provides proof of principle that you can target multiple RAS isoforms safely and achieve clinical responses in patients. So more to come on this, but I am very excited regarding this. Dr. McCormick also presented data from BBO8520, which is what we call a dual state selective covalent inhibitor of G12C. This is able to bind to both the GDP and the GTP bound form of KRAS. And this is another compound that I think we're going to hear more in the near future. It's entering clinical trials towards the end of the year. But again, a very exciting and novel approach compared to the off-state selective inhibitors. Quite recently, towards the end of 2022, we also saw a publication regarding MRTX1133, which is a non-covalent inhibitor of KRAS G12D that has also shown considerable efficacy in preclinical models, and the phase 1 clinical trial of this compound has just started. So this will offer one additional important option for patients with KRAS G12D mutated cancers, which of course are the majority of pancreatic cancer and colorectal cancer, while at the same time representing a substantial portion of the non-small cell lung cancer population. One additional class of agents that I think we'll also hear more in the future are RAS degraders. These are molecules, bifunctional molecules, that can bind to a mutant KRAS allele and then target it for degradation to the cell's protein degradation machinery, which is the proteasome. And we also saw new data presented at AACR from the Astellas compound, ASP3082, with, at least in preclinical models, the compound appeared to be active and induce deep and sustained tumor regressions. And I think a clinical trial is also enrolling patients with the Astellas compound. Finally, I would like to very briefly touch upon alternative approaches to target KRAS mutant tumors, and these involve novel immunotherapy approaches such as TCR T-cell therapy, and more recently, the whole notion that KRAS G12C inhibitors can actually induce MHC class 1 presentation of peptide neoepitopes. This is a very complex process, but basically what it means is that the inhibitor can create an immunogenic peptide that then gets presented to the immune system and can be targeted by engineered T cells. Final slide, and happy to take any questions. I think it's important to move KRAS G12C inhibitors and generally KRAS inhibitors beyond KRAS G12C into earlier disease settings, particularly the context of early stage surgically resectable non-small cell lung cancer. There are 2 clinical trials that are enrolling right now. The first one we're running here at MD Anderson. It's enrolling quite well. It's a phase 2 study of neoadjuvant sotorasib. So here we give sotorasib with chemo, before surgery, 4 cycles of sotorasib and chemo followed by surgery. And we want to assess the major pathologic response. What's the chance that the tumor will have shrunk and we'll see less than 10% viable cells? And then we've got a second study in this space that's run by Dr. Marone at Hopkins, which is the NeoCan study that combines adagrasib with nivolumab, so immunotherapy together with adagrasib, and that's also going to be an exciting study. Multiple people that I would like to thank that contributed to this work, but mostly I want to thank you for your attention. And if there are any questions, and we've got a minute or two or more, happy to take it.
Yeah, you know better than that. Okay, all right. So yeah, we do have a couple of questions that like popped up, but that was fantastic. And I know I kind of like threw your whole game a little bit by interrupting you with questions as we kind of like rolled through it. So
that's the best way.
I appreciate your tolerance with me. Okay. So, all right, I'm going to go back up to one of the earlier ones that I did miss, and it was specific to the G12C inhibitors, because we spent a lot of time on G12C inhibitors, which is granted a huge population. However, a lot of us are not in that space, and we're like trying to figure out like either next plans or whatever for what's up. So I'm going to read the question. Is there any data regarding G12C inhibitor with Avastin? I know that's the trade name, not the actual generic name. For a patient that was like on a G12C and had progression, what is typically like a next step? Do you move to another G12C inhibitor? Do you do a cleanup chemo? What's an immunotherapy? So we know the chess champion that you are, now that I know that. Okay. All right. So we know that. So what would strategically be your next plan? And is it based on different information?
Yeah, that is an excellent question. So first of all, regarding the Avastin, I think that combination is being looked at. We haven't seen any data being reported on that one yet, but that is one of the combos. The combination with vascular targeting agent is a very reasonable one based on the experience that we've got from other oncogene-driven lung cancers, such as EGFR. So I think that's being looked at, but we don't yet have any clear data to support.
And would it matter if it is lung cancer or appendiceal or colorectal? Does that make a difference?
With the angiogenesis inhibitors, you mean? Well, I mean, angiogenesis inhibitors are used in both lung and colorectal. So I think it would be reasonable for both. It would be a reasonable thing to explore, and in both kind of contexts. I think we've got approved drugs in both diseases, and targeting angiogenesis is an important component of treatment paradigms in both diseases. So I think it's relevant for both. With regards to the second question, which is what I would do, especially in G12C after progression, I think in the first instance, I would try to, as I've said, comprehensive sequencing, trying to understand what has caused the progression. And in many cases, I will base, here at MD Anderson, we are a little bit spoiled for choice. So this might not be available across the country, but depending on the mechanisms of resistance that I observe, I might go for a tailored approach. I remember, for example, one of my patients that progressed on a sotorasib earlier on, and at time of progression had multiple different, I think about 6 or 7 mutations in different components of the MAP kinase pathway. So at that point in time, I went for off-license use of sotorasib together with trametinib, with an MEK inhibitor. And actually, that patient did very well. All those, she had a partial response, and all those mutations disappeared. So there are cases where I will go for a personalized approach. That we've got a number of different clinical trials. So we would definitely be interested in continuing G12C inhibitor or a different G12C inhibitor together with another agent, such as a SHP2 inhibitor, or perhaps now with the new G12C on inhibitors or pan-RAS inhibitors. That would be logical things to try. I think if a patient has not been fully exposed to cytotoxic chemotherapy and we don't have a clear mechanism of resistance, I think using chemotherapy would be is also a very reasonable thing.
Yeah, and just as a reminder, we do have an international audience, and so sometimes, first of all, MD Anderson is just totally not an option at all, right? And they don't, and everybody doesn't always have access to the same stuff. Okay, I'm going back through the questions. So I'm going back, and Maureen asked, does the percent of STK11 to percentage of KEAP1 impact your outcomes?
Well, when you say the percentage, you mean as a
I think they're looking at the reports, because a lot of times it'll say
yes,
like
yes,
6% or whatever.
yes.
And if you have a higher of one than another, does it make a difference?
Yeah. So
I'd
so
love
the
to
number?
hear your take on the way that it's explained.
Yeah. So the number that you see on the report refers to the variant allele fraction. So in other words, what number of what fraction of molecules are mutated. I typically, I don't pay too much attention to that with regards to STK11. STK11 are in most cases what we call clonal alterations or truncal alterations. It means that they are present in that original, original clone that gave rise to all the other clones. It's not something that happens only in a very small fraction of tumor cells. It's usually present there in the majority of tumor cells from the very beginning. It's, if you want, the easiest way to think about this, there is an early alteration. It occurs early in the evolution of the cancer, and therefore it is retained. It's not something that the tumor acquires quite late in the game or quite late in its evolution. So the percentage, the variant allele fraction does not play at this point in time a major role in my assessment of STK of commutational status. So I think that's what you're referring to by the percentage in the actual report, because that's not the prevalence. That's what fraction of detected molecules are mutated.
It's not like
PD-L1,
where it's like my PD-L1 is a certain percentage, and that's showing as an indication as far as what treatment options might be best for me.
Yes. So PD-L1 is absolutely can dictate treatment decisions. I think the variant allele fraction of STK11 would probably not. When I detect, it's more the presence versus the absence. If I detect the STK11 mutation or the KEAP1 alteration, I usually call that a positive. Without paying too much attention to the variant allele fraction. There are scenarios where that might be the case, but in the majority of cases, this is a kind of a truncal alteration.
And just so y'all know, I'm going to put back link out. There's on the YouTube channel, we have genetics and genomics, and Dr. Eric Koenig went through and did a fantastic job explaining exactly how that is and what that looks like on our reports. So it's around the biomarker part of it, because it's not necessarily like a percentage of your tumor or something. It's just more a percentage of what was identified in the lab. So it's not pertinent in that. It's not relevant like what you're saying as far as the treatment is concerned. Okay, let's see. Somebody was asking what's the difference between wild and mutated. Here's my take. You can correct me if I'm wrong. Okay. All right. So like you've got two sides of your DNA, right? One from mom, one from dad, right? Okay. And it's supposed to be on again, off again, on again, off again. And instead of it going on again, off again, doing what's supposed to do, which is in its wild state, it made a mistake. And instead of like say G12, instead of being a G on my number 12, it made say a D or an A or an S or whatever on whatever. And so I went from G12, should have been G12G, and instead it went G12D. Is that right?
Yeah, it's right. So the way I describe it to patients in the most easiest way is I call mistakes, mutations are basically spelling mistakes. If you think of a page in a book and you think of your DNA as the code there, which are the sentences, a mutation is basically a spelling mistake in the DNA. And what it does is it gives the wrong, it gives a different instruction. It gives an instruction to make a faulty or an altered protein, because genes give instructions to create proteins. So when you've got a mutation, you're creating a faulty protein, which does exactly what Terri suggested. Instead of being able to to constantly toggle between on and off, it is more geared towards the on state, which then keeps sending signals to the cell to continue to divide, to proliferate, and to do the things that cancer does. Absolutely. Okay.
All right. And so that's wild versus mutated. I'm just going through here. Clinical trials on G12S. Now, we had Kavan Shokat on, I guess it was actually, it's not that long ago, and he was talking about how G12S and G12 are probably looking like they're going to be next. Are you seeing anything on the horizon for that?
I mean, Dr. Shogat has done groundbreaking work on developing the concepts for targeting those difficult to treat alleles. So I think yes, there's going to be studies in the foreseeable future. I don't know exactly when they're hitting first in human, but absolutely, I think we've got what we need to develop inhibitors that target those difficult to treat alleles.
Okay, all right. So you haven't seen anything yet. Okay, upstream versus downstream.
Yeah, that's an excellent kind of question. I think I think there's rationale for doing. I think there's rationale for doing both. I think we have seen most of the success has been, that we've seen so far with combinations has been with EGFR inhibitors, so kind of upstream. SOS1, I think, is coming in as upstream, SHP2 inhibitors. I think the combination with trametinib, at least in non-small cell lung cancer, did not result in considerable efficacy. But I think both approaches are still being explored. I don't think we've got a clear winner yet.
Okay, so there's not a clear winner as far as which way to attack the pathway. Okay. Mm-hmm. But as far as the actual composition of what a pathway looks like, I've got 1,000 slides. We'll post those again. Okay, so if your tumors, or if your metastatic tumors are staying the same size, okay, for a period of time, you're stable, right? Like legit stable. Okay, should you be adding this other treatment or just be happy with being stable?
Yes, that is an excellent kind of question. I think this is a broader discussion in the field right now about the biology of what we call persister cells and what exactly is happening when you have this stability, and what are the signaling networks in these residual drug tolerant cells. So I think intuitively we would want to eradicate those cells. I think we are not happy with stability. Stability is certainly better than the tumor growing, but I think as cancer researchers and as clinicians, we're not happy with stability. I think we want tumor shrinkage, and we want to be eradicating those clones because that's where resistance will emerge. So I think the whole field, I mean, we are devising rational strategies to achieve exactly that, how best to eliminate these persister clones. But in order to eliminate them, we need to understand better what is driving that persistence. I mean, I think there was some interesting data presented at the conference about the Hippo pathway, the Hippo signaling pathway as a generally applicable mechanism of persistence in the context of inhibition of a number of different oncogenic kind of drivers. And we saw a TEAD1 inhibitor that kind of showed interesting results in mesothelioma. This was presented by my colleague Tim Yap. So these are certainly ideas that exist and that are being explored in the context of KRAS mutations. What's the optimal combination to eliminate those persister cells? In the context of a patient that only has a limited number of metastatic sites, so let's say we achieve stability and I can only see 1 or 2 or 3 mutations, what I will very frequently do, and many of my colleagues will do, is consolidate with radiation therapy. So go and offer radiation therapy to sites of persistent disease, precisely with the idea being to try to eradicate these persistent clones. Of course, the problem is bigger when you've got multiple of these sites, because there might be limitations to the efficacy of radiation therapy across a number of different sites. But I think certainly radiation is one approach for a limited number of sites, and we're looking towards different types of systemic therapies precisely to try to eliminate those clones.
Okay, so there's not an easy answer is what I heard on that. But in the meantime, monitor it. If you can radiate it, that's definitely worth a consideration. Irradiate, or even in some cases, even take it out. I mean, it depends on how many there are. I've got patients with really very variable patterns of disease persistence. Sometimes you can only have one area of disease. And, if you can do surgery, take it out and the patient is fit, I might even do it. Radiation is an option as well. Certainly, for multiple disease sites, it's more challenging, and there you have to think. I mean, you can consider doing chemo, you can consider doing a number of different things. Right. Yeah, because every part of me is like, if I was cooking something, it seems like needing something added, not something taken away. Okay, and then where did the CtDNA test, like whether it's a liquid biopsy, fall into this equation as to monitor the disease or their remission?
Yeah, and I think that there are, I think the role of ctDNA in monitoring disease is evolving. I think there are a couple of interesting publications and there are a couple of interesting presentations. I personally use it. I use it quite frequently, both to monitor disease status, but also to detect early resistant clones, which we discussed earlier that are kind of quite important. It may not be as widely available to everyone, and I think before widespread application of ctDNA to monitor disease is applied broadly, we would need to have concrete evidence that it can change outcomes, that it can lead to patients living longer or having more sustained tumor regressions. But I think in my practice, I use it quite frequently to catch disease recurrence and the mechanisms of resistance, as early as possible.
Okay. Okay, so I'm going to read this question. When rechecking any changes in tumor mutation, is liquid biopsy a good way to go comparatively? Okay, because we still hear, tissue is the issue, right? And is the gold standard, right?
No, it is an excellent question, Terry. The answer there is, there are practical considerations. Obviously, it's much more difficult to obtain tissue biopsies. However, tissue biopsies are of value for a number of reasons. First of all, histological transformation is not captured by circulating tumor DNA. So, we are seeing this transdifferentiation to squamous. I have no doubt that in the future, we're also going to see transformation to small cell or other in histology. So that cannot be captured by ctDNA. And also sometimes you do see differences between ctDNA and tissue. I still remember one of the classical examples, one of my patients, again, multiple mechanisms of resistance identified on circulating tumor DNA. And then we decided to go ahead and biopsy not one, but two actually different lesions. Interestingly, none of the mutations that we detected in the blood were present in the progressing lesions. So there are cases where you see this discordance and you don't know what to do about it. So I tend to recommend tissue biopsy as well, assuming I assess that this is safe to do. If something is very difficult to access, then we have to accept that we can't do it, and we'll have to go with ctDNA. But if superficial tumors are superficial or easy to access, I don't think it's unreasonable to try to obtain a kind of a biopsy there as well. And this will become, I think, even more applicable as our options expand. I think when you propose the concept of a biopsy to a patient, ideally you want to say that this is what we will do if the biopsy result shows this, or this is what we will do if the biopsy result shows something different. So we need to have options. And I think as the compendium of available trials, especially with the novel inhibitors that target multiple KRAS alleles, evolve, I think we will have strong rationale for proposing biopsies at the time of progression, because there might well be options that are tailored to what we find in that biopsy.
Because what I hear is that if you have progression, you really need to have a biopsy, whether it's liquid biopsy and they run enough blood, or tumor biopsy, you need to know what it is that's going on, because it can change. And if you change it, then it's going to make a difference. You need to have,
at the very least, liquid.
Change the treatment too.
Yes, at the very least, liquid. I do it in all my patients treated with G12C inhibitors.
We don't all get it, you. What can I tell you? Okay, we're just doing our best. Okay, but I know that if you can't get to the tumor to biopsy, then you need to be hitting it in some way to get the information, right? Okay, I'm a non-small lung cancer patient, have been sensitive to any drugs. I'm just reading this. One dose of pembro with chemo leads to grade 4 autoimmune liver, later cured with steroids. Is there any flexibility in that type of a dosage of a cycle lengthening or re-challenging Keytruda as a last resort?
Yeah, that's a very tough scenario, and I have many patients in that kind of category. I mean, usually the official guidelines for grade 4, I mean, if it was grade 4 liver toxicity, would be not to re-challenge with an immune checkpoint inhibitor in that in that case. From my experience, and I don't know whether this is the case here, but in my experience, many patients that experience this type of immune-related adverse events tend to have pretty sustained regressions even without the further immunotherapy, which can happen. I've got many patients that developed quite severe immune-related adverse events, and we stopped immunotherapy, but the disease stayed under control for a long time. Would I re-challenge? I think it would be a very difficult scenario, a very difficult question. I would probably not re-challenge at this point in time. I would go through different lines of therapy, and I would only re-challenge if there was, or consider re-challenging if there was no other option. But in someone with grade 4, the official guidance is that you should not re-challenge because it's not safe.
It's not safe. Okay. Let's see, I'm going to post this. Let's see. I don't think I have any other things in here. Okay. I unfortunately, as I mentioned to you, I had to leave the meeting early, and so I wasn't able to hear a lot of the stuff that was going on, right? That was happening, and I was very upset because I know Channing Durr posted a really nice slide. He had like all the clinical trials and everything, and I haven't been able to kind of like pull it all back in. Is there anything else? Like, you were there, okay? You're still sunburnt, okay? so you tell me, what did I miss?
I think
just talk to me. Don't talk to the slides. Talk to me.
Yes. I think there is a lot of excitement on the horizon about targeting KRAS. I think we are seeing, first of all, multiple different KRAS inhibitors. I mean, G12C is at the forefront. I mean, those are the ones that were developed first, and they're going to becoming more and more potent. But we're also seeing, I'm quite excited about approaches to target multiple isoforms of RAS. I was impressed by the data that was presented by Revolution Medicines. It was press release beforehand. I think that represents a very important strategy. Whether that is going to work as monotherapy, single agent, or whether that's going to be best suited in combination with a mutant selective inhibitor remains to be seen. I think there's more. The KRAS G12C on inhibitors that are coming, the novel KRAS G12C on inhibitors may be more potent. They target the on state as well. That is exciting. There's also a lot of excitement, I think, about immunotherapy approaches like the T-cell therapies. We didn't discuss that in great detail. That is in a way a completely independent approach about targeting KRAS tumors, and that is definitely not limited to KRAS G12C. So we saw an excellent presentation in the plenary session on the first day on Saturday, and I think though we will get more clinical data for all of these approaches in the near future. But I think that T-cell therapies are a very promising approach, especially in cases where mutant selective inhibitors have run their course, if you want, and the patient has developed resistance. I think that is an area that I am quite excited about, and I think that it's also important to acknowledge that now we've got an important anchor on which to base combination therapy. So we've got KRAS inhibitors, and now we're going to be combining them with different agents in a rational manner. And in a way, the data, our work, perhaps it's most important that its biggest significance in a way that it sets the commutational landscape of KRAS G12C mutant non-small cell lung cancer. It tells us which patients do reasonably well with one drug, with what we've got right now, which patients require a more intensive therapeutic approach. And it also perhaps provides a roadmap or a blueprint for how to personalize combination therapeutic strategies based on the individual, on the genomic status of individual tumors, not just KRAS itself, but the other genes that co-occur with KRAS. So I've got no doubt that we will develop rational and effective combinations for KRAS with KRAS plus that will be tailored to the to the commutational status of individual tumors. So I think that there is hope not just for the distant future. I think there is hope for right now. I think these agents are entering clinical development, and some of them are showing preliminary efficacy. And I think we've got a number of different clinical trials. And I think I think part of what you're doing, Terri, by having this support group where people can get access to the best knowledge that's out there, the clinical trials network, and try to find the clinical trial that's mostly suited to them is enormously powerful. I think this is not the age of despair. This is the age of hope for patients with KRAS mutated tumors. G12C has led the way, but in leading the way, it has provided a blueprint for how to target KRAS and the different KRAS alleles. We are in a very different place from where we were even 5 years ago, when I was kind of working on RAS, and everyone was saying that's very interesting, but how do we treat it? Now we can treat it. We're not where we want to be, but I think we are getting there. And so I think there is KRAS is still an enormous carries an enormous human burden. It's a very difficult to treat disease. It's but we're making progress, and I think there's more to come. I'm optimistic about not just the distant future, but the foreseeable future.
Well, that's good to hear, because most of us 5 years ago didn't know anything about a KRAS, and I certainly had no idea that it was going to become so important in my life, let alone the strategy of what it was going to take for me to stay alive. So based on that, I thank you so much for
Absolutely.
your time. And I mean, you stayed late, and it's like you're still going, and I know you've got to be exhausted from, like, you come out of these things and it's like, I mean, it's just like there's so much information, like it's information overload, right? It's great, but it's like a lot. So
it's my absolute pleasure, and happy to come back anytime. I think you need to be applauded for this effort, and the whole of the KRAS Kickers community, I think, is an incredible initiative. And I'm enormously privileged to be part of it, and happy to come back anytime.
Well, we appreciate you, and I also appreciate the sponsors that allow us to not have to ask people for memberships or anything that sort of stuff. And so our champion partner, Amgen, sustaining partners, AstraZeneca, supporting partner, Mirati Therapeutics, and establishing partners, Revolution Med. And I am just hopeful that next time I get together with you, and whether it's on a Zoom call or in person, we have something even better, because right now it's not even how to get in a clinical trial. We start identifying the clinical trials, and it's it's almost like we're fighting slots, like lottery tickets. And so you guys, I appreciate you're doing what you need to do, but I think you need to get back to work. And get it out there. So thank you again for joining, and everybody else, thank you guys for all being here and being wonderful. I'm going to be posting this video in the YouTube here channel as quickly as possible, and I hope to see y'all again soon. Just stay tuned for more. Okay, thank you guys. Bye now. Thanks.
Bye.